Hello and welcome to the Coding Corner, Medical Coding Education. Today we will be covering chapters 13, 14, and 15 of the ICD-10 CM chapter-specific coding guidelines. My name is Kristen Robinson. I am a coder, auditor, and educator, and let's get into it. The first chapter that we are covering today is Chapter 13, Diseases of the Musculoskeletal System and Connective Tissue, codes M00 through M99. First up, we have site and laterality. Most of the codes within Chapter 13 have site and laterality designations. The site represents the bone, joint, or muscle involved. So bone versus joint. For certain conditions, the bone may be affected at the upper or lower end. For example, avascular necrosis of bone, M87, osteoporosis, M80, and M81. Though the portion of the bone affected may be at the joint, the site designation will be the bone, not the joint. So when you have multiple sites, the codes describing specified sites are assigned individually by site when documented. When the specified site or sites are not documented, assign the appropriate code for multiple sites. When we have acute traumatic versus chronic or recurrent musculoskeletal conditions, many musculoskeletal conditions are a result of a previous injury or trauma to a site or are recurrent conditions. Bone, joint, or muscle conditions that are the result of a healed injury are usually found in Chapter 13. Recurrent bone, joint, or muscle conditions are also usually found in Chapter 13. Any current acute injury should be coded to the appropriate injury code from Chapter 19. Chronic or recurrent conditions should be generally coded with a code from Chapter 13. If it is difficult to determine from the documentation in the record which code is best to describe a condition, please make sure that you query your provider. Next up, when we are coding pathological fractures, the seventh character A is for use as long as the patient is receiving active treatment for the fracture. While the patient may be seen by a new or different provider over the course of treatment for a pathological fracture, assignment of the seventh character is based on whether the patient is undergoing active treatment and not whether the provider is seeing the patient for the first time. The seventh character D is to be used for encounters after the patient has completed active treatment for the fracture and is receiving routine care for the fracture during the healing or recovery phase. The other seventh characters listed under each subcategory in the tabular list are to be used for subsequent encounters for treatment of problems associated with the healing, such as malunions, non-unions, and sequelae. Care for complications of surgical treatment for fracture repairs during the healing or recovery phase should be coded with the appropriate complication codes. If you would like additional information on this, you can see section 1C19 for coding of traumatic fractures. When it comes to osteoporosis, osteoporosis is a systemic condition, meaning that all the bones of the musculoskeletal system are affected. Therefore, site is not a component of these codes under category M M81 for osteoporosis without current pathological fracture. The site codes under category M80 for osteoporosis with current pathological fracture identify the site of the fracture, not the osteoporosis. So now let's get into it a little bit deeper. Osteoporosis without pathological fracture. Category M81, osteoporosis without current pathological fracture, is for use for patients with osteoporosis who do not currently have a pathological fracture due to osteoporosis, even if they have had a fracture in the past. For patients with a history of osteoporosis fractures, status code Z87.310 for personal history of a healed osteoporosis fracture should follow the code from M81. So when we have osteoporosis with a current pathological fracture, category M80 for osteoporosis with current pathological fracture is for patients who have a current pathological fracture at the time of the encounter. The codes under M80 identify the site of the fracture. A code from category M80, not a traumatic fracture code, should be used for any patient with known osteoporosis who suffers a fracture, even if the patient had a minor fall or trauma, if that fall or trauma would not usually break a normal, healthy bone. Last for this slide, multisystem inflammatory syndrome. If you want additional information on this particular section, see section 1C.1G1L for multisystem inflammatory syndrome. Our next chapter is chapter 14, diseases of the genitourinary system, codes N00 through N99. This is going to focus specifically on chronic kidney disease. This is the only section for chapter 14 in the ICD-10 guidelines. For chronic kidney disease, we have 3 guidelines we need to follow. Number 1, stages of chronic kidney disease, or CKD. The ICD-10-CM classifies CKD based on severity. The severity of CKD is designated by stages 1 through 5. Stage 2, code N18.2, equates to mild CKD. Stage 3 codes to N18.30 through N18.32. And those codes differ based on whether it is stage 3A, 3B, or 3 unspecified. So N18.30 is going to be your unspecified stage 3. N18.31 is for stage 3A, and N18.32 is for stage B. And these equate to moderate CKD. Stage 4 for code N18.4 equates to severe CKD. We also have code N18.6 for end-stage renal disease, or ESRD. It is assigned when the provider has documented end-stage renal disease. Now, I will also tell you that there is stage 5, which is N18.5. If both a stage from CKD and end-stage renal disease are documented, assign code N18.6 only. Our second guideline for this chapter, chronic kidney disease and kidney transplant status. Patients who have undergone kidney transplant may still have some form of chronic kidney disease. Because the kidney transplant may not fully restore the kidney function, therefore, The presence of CKD alone does not constitute a transplant complication. Assign the appropriate N18 code for the patient's stage of chronic kidney disease and then code Z94.0 for kidney transplant status. If a transplant complication such as a failure or rejection or other transplant complication is documented, see section 1C19.G for information on coding complications of a kidney transplant. If the documentation is unclear as to whether the patient has a complication of the transplant, please make sure you query your provider. And the last for this particular chapter is our last guideline, number 3, chronic kidney disease with other conditions. Patients with CKD may also suffer from other serious conditions, most commonly diabetes mellitus and hypertension. The sequencing of the CKD code in relationship to the codes for other contributing conditions is based on the conventions in the tabular list. For instance, with diabetes, there is a combination code for diabetes with CKD, but you still need to code your CKD stage secondary. Also with hypertension. Now, as we previously talked about in the circulatory system in the last video, which if you haven't checked that out, please make sure you go check that out over here on YouTube. With hypertension, you have hypertension with CKD. You also have hypertension with CKD and heart failure or CKD without heart failure. And there are hypertension combination codes for those relationships. But I also want to make it known that diabetes mellitus and hypertension both have a causal relationship with CKD, meaning there can be the assumption that they are related unless the provider distinctly documents that they are unrelated. Make sure that you look at your conventions when it comes to the word with and due to. Those are all key words when it comes to these conditions. If you would like additional information, you can see section 1C9 for hypertensive chronic kidney disease and 1C19 for chronic kidney disease and kidney transplant complications. Our last chapter for today is chapter 15, pregnancy, childbirth, and the puerperium. These are codes O00 through O9A. And I will tell you, this has got a lengthy amount of guidelines, and they are very important because if you've not previously heard the other videos, chapter 15 takes precedence over the other chapters within the coding guidelines for a patient with pregnancy, childbirth, and the puerperium because they have to represent what's currently going on with the patient. There are multiple guidelines for this section, so please make sure you follow closely. First up, we have the general rules for obstetric cases. Number 1, codes from chapter 15 and sequencing priority. Obstetric cases require codes from chapter 15. Codes range O00 through O9A. Pregnancy, childbirth, and the puerperium. Chapter 15 codes have sequencing priority over codes from other chapters. Additional codes from other chapters may be used in conjunction with chapter 15 codes to further specify conditions. Should the provider document that the pregnancy is incidental to the encounter, then you'll use code Z33.1 for pregnant state incidental should be used in place of a Chapter 15 code. It is the provider's responsibility to state that the condition is being treated is not affecting the pregnancy. Number 2, Chapter 15 codes used only on the maternal record. Remember, as long as the fetus is within the mother, you are only coding for the maternal record. It is not until the baby is born that they will go on their own record. Number 3, the final character for trimester. The majority of codes in Chapter 15 have a final character indicating the trimester of pregnancy. The time frames for the trimesters are indicated at the beginning of the chapter. If trimester is not a component of a code, it is because the condition always occurs in a specific trimester, or the concept of trimester of pregnancy is not applicable. Certain codes have characters for only certain trimesters because the condition does not occur in all trimesters, but it may occur in more than just one. Assignment of the final character for trimester should be based on the provider's documentation of the trimester or the number of weeks, or we say weeks of gestation, for the current admission or encounter. This applies to the assignment of trimester for pre-existing conditions, as well as those that develop during or are due to the pregnancy. The provider's documentation of the number of weeks may be used to assign the appropriate code identifying the trimester. Whenever delivery occurs during the current admission and there is a in childbirth option, the obstetric complication being coded, the in childbirth code should be assigned. When the classification does not provide an obstetric code with an in childbirth option, it is appropriate to assign a code describing the current trimester. Number 4, selection of trimester for inpatient admissions that encompass more than one trimester. In instances when a patient is admitted to the hospital for complications of pregnancy during one trimester and remains in the hospital into a subsequent trimester, the trimester character for the antepartum complication code should be assigned based on the trimester when the complication developed, not the trimester of the discharge. If the condition developed prior to the current admission encounter or represents a pre-existing condition, the trimester character for the trimester at the time of admission or encounter should be assigned. Number 5, unspecified trimester. Each category that includes codes for trimester has a code for unspecified trimester. The unspecified trimester code should rarely be used, such as when the documentation in the record is insufficient to determine the trimester and it is not possible to obtain clarification. I cannot stress enough that if you have the ability to query your provider, that you make sure that they document to the highest specificity known at the time of the encounter. Number 6, the 7th character for fetus identification. Where applicable, a 7th character is to be assigned for certain categories for O31, 32, O33.3 through O33.6, O35, 36, O40, 41, O60.1, O60.2, O64, and O69 to identify the fetus for which the complication code applies. When you assign 7th character 0, this is for single gestations, when the documentation in the medical record is insufficient to determine the fetus affected and it is not possible to obtain clarification, again, query your provider, educate them to document at the highest specificity. And lastly, when it is not possible to clinically determine which fetus is affected. Last up for this slide, we have number 7 for completed weeks of gestation. In ICD-10-CM, completed weeks of gestation refers to full weeks. For example, if the provider documents gestation at 39 weeks and 6 days, you will use the code for 39 weeks of gestation, as the patient has not reached 40 completed weeks. So next up we have selection of OB principal or first listed diagnosis. Number 1, routine outpatient prenatal visits. For routine outpatient prenatal visits, when no complications are present, a code from category Z34 for encounter for supervision of normal pregnancy should be used as the first listed diagnosis. These codes should not be used in conjunction with Chapter 15 codes. Number 2, supervision of high-risk pregnancy. Codes from category 009 for supervision of high-risk pregnancy are intended for use only during the prenatal period. For complications during the labor or delivery episode as a result of a high-risk pregnancy, assign the applicable complication codes from Chapter 15. If there are no complications during the labor or delivery episode, assign code 080 for encounter for full-term uncomplicated delivery. For routine prenatal outpatient visits for patients with high-risk pregnancies, a code from category 009 for supervision of high-risk pregnancy should be used as the first listed diagnosis. Secondary Chapter 15 codes may be used in conjunction with these codes if appropriate. Number 3, episodes when no delivery occurs. In episodes when no delivery occurs, the principal diagnosis should correspond to the principal complication of the pregnancy which necessitated the encounter. Should more than one complication exist, all of which are treated or monitored, any of the complications codes may be sequenced. Number 4, when a delivery occurs. When an obstetric patient is admitted and delivers during that admission, the condition that prompted the admission should be sequenced as the principal diagnosis. If multiple conditions prompted the admission, sequence the one most related to the delivery as the principal diagnosis. A code for any complication of the delivery should be assigned as an additional diagnosis. In cases of cesarean delivery, if the patient was admitted with a condition that resulted in the performance of a cesarean procedure, that condition should be selected as the principal diagnosis. If the reason for the admission was unrelated to the condition resulting in the cesarean delivery, the condition related to the reason for the admission should be selected as the principal diagnosis. Number 5, outcome of delivery. A code from category Z37, outcome of delivery, should be included on every maternal record when the delivery has occurred. Remember, these codes are not to be used on subsequent records or on the newborn record. Next up, we have pre-existing conditions versus conditions due to pregnancy. Certain categories in Chapter 15 distinguish between conditions of the mother that existed prior to pregnancy or pre-existing and those that are a direct result of pregnancy. When assigning codes from Chapter 15, it is important to assess if the condition was pre-existing prior to pregnancy or developed during or due to the pregnancy in order to assign the code category. Categories that do not distinguish between pre-existing and pregnancy-related conditions may be used for either. It is acceptable to use codes specifically for the puerperium with codes complicating pregnancy and childbirth if a condition arises postpartum during the delivery encounter. For pre-existing hypertension and pregnancy, Category 010 for pre-existing hypertension complicating pregnancy, childbirth, and the puerperium includes codes for hypertensive heart and hypertensive chronic kidney disease. When assigning one of the 010 codes that includes hypertensive heart disease or hypertensive chronic kidney disease, it is necessary to add a secondary code from the appropriate hypertension category to specify the type of heart failure or chronic kidney disease, as we spoke about earlier in today's presentation. If you want additional information on this, see section 1C9 for hypertension. For fetal conditions affecting the management of the mother. Number 1, codes from categories 035 and 036. Codes from categories 035, maternal care for known or suspected fetal abnormality and damage, and 036 for maternal care for other fetal problems, are assigned only when the fetal condition is actually responsible for modifying the management of the mother. For example, by requiring diagnostic studies, additional observation, special care, or termination of the pregnancy. The fact that the fetal condition exists does not justify assigning the code from this series to the mother's record. Last up for this slide, in utero surgery. In cases when surgery is performed on the fetus, a diagnosis code from category 035, maternal care for known or suspected fetal abnormality and damage, should be assigned identifying the fetal condition. Assign the appropriate procedure code for the procedure performed. No code from Chapter 16, the perinatal codes, should be used on the mother's record to identify fetal conditions. Surgery performed in utero on a fetus is still coded as an obstetric encounter. First up for this slide, we have HIV infection in pregnancy, childbirth, and the puerperium. During pregnancy, childbirth, or the puerperium, a patient admitted because of an HIV-related illness should receive a principal diagnosis from subcategory 098.7 for human immunodeficiency disease, or HIV, complicating pregnancy, childbirth, and the puerperium, followed by the code or codes for the HIV-related illness or illnesses. Patients with asymptomatic HIV infection status admitted during pregnancy, childbirth, or the puerperium should receive codes of 098.7 and Z21 for asymptomatic human immunodeficiency virus or HIV infection status. For diabetes mellitus in pregnancy, diabetes mellitus is a significant complicating factor in pregnancy. Pregnant patients who are diabetic should be assigned a code from category 024. Diabetes mellitus in pregnancy, childbirth, and the puerperium first, followed by the appropriate diabetes code or codes from E08 through E13 from Chapter 4. Long-term insulin use and oral hypoglycemics. If you want additional information on this section, see section I or 1C 4.A.3 for information on the long-term use of insulin and oral hypoglycemics. For gestational or pregnancy-induced diabetes, gestational pregnancy-induced diabetes can occur during the second and third trimester of pregnancy in patients who were not diabetic prior to pregnancy. Gestational diabetes can cause complications in the pregnancy similar to those of pre-existing diabetes. It also puts the patient at a greater risk of developing diabetes after pregnancy. Codes for gestational diabetes are in subcategory O24.4 for gestational diabetes mellitus. No other code from category O24 for diabetes mellitus in pregnancy, childbirth, and the puerperium should be used with a code from O24.4. The codes under subcategory O24.4 include diet-controlled, insulin-controlled, and controlled by oral hypoglycemic drugs. If a patient with gestational diabetes is treated with both diet and insulin, only the code for the insulin-controlled is required. If a patient with gestational diabetes is treated with both diet and oral hypoglycemic medications, only code for the controlled by oral hypoglycemic drugs is required. Codes Z79.4 for long-term current use of insulin, Z79.84 for long-term current use of oral hypoglycemic drugs, and Z79.85 for long-term current use of injectable non-insulin anti-diabetic drugs should not be assigned with codes from subcategory O24.4. An abnormal glucose tolerance in pregnancy is assigned a code from subcategory O99.81 for abnormal glucose complicating pregnancy, childbirth, and the puerperium. Got two more sections on this slide. Next up, we have sepsis and septic shock complicating abortion, pregnancy, childbirth, and the puerperium. When assigning a Chapter 15 code for sepsis complicating abortion, pregnancy, childbirth, or the puerperium, a code for the specific type of infection should be assigned as an additional diagnosis. If severe sepsis is present, a code from subcategory R65.2 for severe sepsis and code or codes for the associated organ dysfunction or functions should also be assigned as additional diagnoses. Puerperal sepsis. Code 085 for puerperal sepsis should be assigned with a secondary code to identify the causal organism. For example, for bacterial infection, assign a code from category B95 through B96. Bacterial infections and conditions classified elsewhere. A code from category A40 for streptococcal sepsis or A41 other sepsis should not be used for puerperal sepsis. If applicable, use additional codes to identify severe sepsis from R65.2 and any associated acute organ dysfunction. Code 085 should not be assigned for sepsis following an obstetric procedure. See section 1C.1.D.5.B for sepsis due to a post-procedural infection. Now, for alcohol, tobacco, and drug use during pregnancy, childbirth, and the puerperium, we have 3 guidelines to follow in this section. Number 1, alcohol use during pregnancy, childbirth, and the puerperium. Codes under subcategory 099.31, alcohol use complicating pregnancy, childbirth, and the puerperium, should be assigned for any pregnancy case when a patient uses alcohol during the pregnancy or postpartum. A secondary code from category F10 for alcohol-related disorders should also be assigned to identify manifestations of the alcohol use. Number 2, tobacco use during pregnancy, childbirth, and the puerperium. Codes under subcategory 099.33 for smoking, tobacco, complicating pregnancy, childbirth, and the puerperium should be assigned for any pregnancy case when a patient uses any type of tobacco product during the pregnancy or postpartum. A secondary code from category F17 for nicotine dependence should also be assigned to identify the type of nicotine dependence. And number 3, drug use during pregnancy, childbirth, and the puerperium. Codes under subcategory 099.32 for drug use complicating pregnancy, childbirth, and the puerperium should be assigned for any pregnancy case when a patient uses drugs during the pregnancy or postpartum. This can involve illegal drugs or inappropriate use or abuse of a prescription drug. Secondary code or codes from categories F11 through F16 and F18 through F19 should also be assigned to identify the manifestations of the drug use. For poisoning, toxic effects, adverse effects, and underdosing in a pregnant patient, a code from subcategory 09A.2 for injury, poisoning, and certain other consequences of external causes complicating pregnancy, childbirth, and the puerperium should be sequenced first, followed by the appropriate injury, poisoning, toxic effect, adverse effect, or underdosing code, and then the additional code or codes that specify the condition caused by the poisoning, toxic effect, adverse effect, or underdosing. See section 1C19 for adverse effects, poisoning, underdosing, and toxic effects. When we have a normal delivery, you're going to use code 080. Code 080 should be assigned when a patient is admitted for a full-term normal delivery and delivers a single healthy infant without any complications antepartum, during the delivery, or postpartum during the delivery episode. Code 080 is always a principal diagnosis. It is not to be used if any other code from Chapter 15 is needed to describe a current complication of the antenatal, delivery, or postnatal period. Additional codes from other chapters may be used with code 080 if they are not related to or are in any way complicating the pregnancy. When we have an uncomplicated delivery with resolved antepartum complication, code 080 may be used if the patient had a complication at some point during the pregnancy, but the complication is not present at the time of the admission for the delivery. And number 3, outcome of delivery 4080. Z37.0 for single live birth is the only outcome of delivery code appropriate for use with 080. Now we have our the peripartum and postpartum periods. There again are several guidelines that we must follow in this section as well. Number 1, peripartum and the postpartum period. The postpartum period begins immediately after delivery and continues for 6 weeks following delivery. The peripartum period is defined as the last month of pregnancy to 5 months postpartum. Number 2, peripartum and postpartum complication. A postpartum complication is any complication occurring within a 6-week period. Number 3, pregnancy-related complications after the 6-week period. Chapter 15 codes may also be used to describe pregnancy-related complications after the peripartum or postpartum period if the provider documents that the condition is pregnancy-related. Number 4, admission for routine postpartum care following delivery outside the hospital. When the mother delivers outside the hospital prior to admission and is admitted for routine postpartum care and no complications are noted, code Z39.0 for encounter for care and examination of mother immediately after delivery should be assigned as the principal diagnosis. Number 5, pregnancy-associated cardiomyopathy. Pregnancy-associated cardiomyopathy code 090.3 is unique in that it may be diagnosed in the 3rd trimester of pregnancy, but may continue to progress months after delivery. For this reason, it is referred to as a peripartum cardiomyopathy. Code 090.3 is only for use when the cardiomyopathy develops as a result of the pregnancy in a patient who did not have pre-existing heart disease. Next, we have code 094 for sequelae of complication of pregnancy, childbirth, and the puerperium. First up, code 094 for the sequelae of a complication of pregnancy, childbirth, and the puerperium is for use in those cases when an initial complication of a pregnancy develops as a sequela or sequelae requiring care or treatment at a future date. Number 2, after the initial postpartum period. This code may be used at any time after the initial postpartum period. And number 3, sequencing of code 094. This code, like all sequelae codes, is to be sequenced following the code describing the sequelae of the complication. For this slide, we're going to start off with termination of pregnancy and spontaneous abortions. Number 1, abortion with live-born fetus. When an attempted termination of pregnancy results in a live-born fetus, assign code Z33.2 for encounter for elective termination of pregnancy and a code from category Z37 for outcome of delivery. Number 2, retained products of conception following an abortion. Subsequent encounters for retained products of conception following a spontaneous abortion or elective termination of pregnancy without complications are assigned 003.4 for incomplete spontaneous abortion without complication, or 007.4 for failed attempted termination of pregnancy without complication. This advice is appropriate even when the patient was discharged previously with a discharge diagnosis of complete abortion. If the patient has a specific complication associated with the spontaneous abortion or elective termination of pregnancy, in addition to retained products of conception, assign the appropriate complication code, for example, O03, O04, and O07, instead of code O03.4 or O07.4. Number 3, complications leading to abortion. Codes from Chapter 15 may be used as additional codes to identify any documented complications of the pregnancy in conjunction with codes in the categories O04, O07, and O08. For hemorrhage following an elective abortion, for hemorrhage post-elective abortion, assign code O04.6, delayed or excessive hemorrhage following or induced termination of pregnancy. Do not assign code O72.1 for other immediate postpartum hemorrhage, as this code should not be assigned for post-abortion conditions. When it comes to abuse in a pregnant patient, for suspected or confirmed cases of abuse of a pregnant patient, a code or codes from subcategory O9A.3 for physical abuse complicating pregnancy, childbirth, and the puerperium, O9A4 for sexual abuse complicating pregnancy, childbirth, or the puerperium, and O9A.5 psychological abuse complicating pregnancy, childbirth, and the puerperium, to identify any associated current injury due to physical abuse, sexual abuse, and the perpetrator of abuse. See Section 1C19 for adult and child abuse, neglect, and other maltreatment. Last on this slide, and finishing our presentation for today, is COVID-19 infection in pregnancy, childbirth, and the puerperium. During pregnancy, childbirth, and the puerperium, when COVID-19 is the reason for the admission or encounter, code O98.5, other viral diseases complicating pregnancy, childbirth, and the puerperium, should be sequenced as the principal or first listed diagnosis, and code U07.1 for COVID-19, and the appropriate codes for associated manifestations should be assigned as additional diagnoses. Codes from Chapter 15 still always take sequencing priority. If the reason for the admission or encounter is unrelated to COVID-19, but the patient has also been diagnosed with COVID-19 during the admission or encounter, the appropriate code for the reason for the admission or encounter should be sequenced as principal first listed diagnosis, and codes O98.5 and U07.1, as well as the appropriate codes for the associated COVID-19 manifestations, should be assigned as additional diagnoses. That's going to close us out for today's presentation. If you enjoyed today's presentation, please make sure you share it out. You hit that bell to be notified for all future sessions, and make sure you come over on the Facebook page for the Coding Corner, and also don't forget that we are over on LinkedIn now. We have a LinkedIn business page for the Coding Corner Medical Coding Education, and today's only resource is ICD-10 CM Fiscal Year 2026. I want to thank everyone for listening to this session, and please feel free to give us a like and a review if you enjoyed this session and would like further sessions like this one. Thank you all and have a great day.